for this year. These will be held every second Friday this time. And notice is fairly short for this one. We're just still in the later part of the schedule. We have an excellent series of speakers coming up for the rest of the fall. Beginning with Peter today. So Peter Dixon is a MD, a PhD candidate in clinical epidemiology. You may have seen his present here earlier this year on binaural versus monaural cochlear implants. And he's here today to talk about work that he's been doing with me and Dave Urbach on how the word cancer affects patient preferences in the context of low-risk thyroid malignancies. And it's a very informal group we have here today, so I think we can welcome questions as we go. Peter's going to give the beginning part of this talk, and I'm going to jump in the middle and talk about the methods a bit and the results, and Peter's going to finish off.
Yeah, thanks. I've had many suggestions that I should pursue a PhD instead of a master's. That's by far the least subtle. I'm a master's student. But thanks for coming. So as a bit of overview, I'll just be chatting a little bit about the clinical background to get everyone up to speed about papillary thyroid cancer. And then, as George mentioned, we'll talk a bit about some of the methods and some of the distribution methods we use to collect our data, and then go into results and the conclusions. So papillary thyroid cancer is a fairly indolent cancer, and it's one whose incidence is rising faster than any other malignancy in the U.S. And similar trends in Canada. It is now represents about 3.1% of incident cancers in the U.S. And despite that, the mortality rate has been fairly consistent, and it is has a fairly good prognosis, with almost 100% sort of 5-year relative survival for localized disease. And predominantly, most of the increased incidence of this tumor are due to the papillary variety of thyroid cancer, and almost all of them are small tumors measuring less than a centimeter. We call them micropapillary cancers. So those are especially low-risk tumors. And because of that, there's been increasing interest in active surveillance rather than the typical treatment for this tumor, which would be surgery, removing a part or all of the thyroid. And this is just some data from observational studies that have shown that the cause-specific survival during active surveillance is 100% essentially, and there is some incidence of a tumor growing, and usually that is taken as an indication for surgery, which all the patients went through successfully. And one of the boundaries to implementing an active surveillance strategy and recruiting patients for trials is that you tell patients they have cancer, and you tell them we're not going to do anything about it. And for a lot of people, that is sort of troublesome and difficult to get over. And we hypothesize, and many others have suggested, that the word cancer has something to do with that. There have been a number of qualitative studies that have looked at patient, the feelings that the word cancer invokes in patients, many of them related to death and fear and inability to control the cancer, and also this kind of desire or impetus to have aggressive treatment in order to treat that cancer. So certainly something in the context of a very low-risk malignancy like papillary thyroid cancer is very unlikely to cause any symptoms or cause death. And it becomes a challenging hurdle to jump over when we talk about treatment. So our research question was, can the label given to a thyroid neoplasm affect patient decision-making? In other words, does cancer change how people think about their disease? The word cancer change how people think about their disease? And if so, how influential is that label relative to other attributes of a cancer diagnosis that we think should be more important to people, that we think that patients should be basing their decisions on, like the treatments that they're going to undergo and the prognosis of their disease? And to do this, we used a methodology that some of you might be familiar with called the discrete choice experiment. And essentially, I think it has its roots in marketing research, actually, where it essentially is a design whereby you describe options that are available to consumers or to patients according to a list of attributes. And one of the assumptions being that you can completely describe the scenario according to these attributes. And each of those attributes has a certain number of levels, and those levels vary, and people are asked to indicate which profile of attributes they prefer. And the proportion of the the number of times people choose a particular profile of attributes over another is proportional to how much they're valued. And George will talk a little bit more about the analysis as we go forward. Just to give you a little bit more of a clear understanding of what we did, I'll show you guys the exact exercise that we had people go through, and we'll ask you in the room to follow along and try to do it as well. So imagine that you are now visiting your doctor to review the results of a test that you did on your that were done on your thyroid gland, which is a small gland in your neck. And you had two tests performed, the first being an ultrasound scan, which is an imaging technique to measure the lump, and the second being a needle biopsy, so that some doctors could look at it under the microscope and tell you what it is. With the results of that test, there are two treatments that you and your doctor might decide on, the first being partial thyroidectomy, removing half of the thyroid gland, and the second being active surveillance. Major risks related to surgery are a risk of having a hoarse voice because one of the nerves that controls your vocal cords runs really close by. You may have a chance of requiring to take a pill daily for the rest of your life to replace your thyroid hormone. You will almost certainly have a scar, and there's a very low chance that you might need a reoperation in the emergent setting if there's some bleeding after the operation. And the alternative is active surveillance, and that would involve you coming in for an ultrasound scan about every year. And the major risk being that you may have some emotional anxiety related to not knowing the status of your condition in between visits. So here's the first choice set. So now you're visiting your doctor. You're going to go discuss the test results. And if you could, just think about which scenario you would prefer. Scenario A, where the biopsy report is a papillary thyroid nodule, and your surgeon decides to go forward with surgery. And after that, you have a 2% chance of the condition coming back. Alternatively, you're diagnosed with a papillary thyroid cancer and you decide on active surveillance. And there's a 1% chance of the condition coming back. So just think about it for a second. And then if you could hands up for scenario A. Nobody. And B? Okay.
Choice.
What's that?
You have to make a choice if you're doing that.
You have to make a choice, yeah. There is, sometimes in discrete choice experiments, we have an option that says I would choose none. We did not provide that option, so you don't have that option. In choice set 2, we'll do 3 of these. Choice set 2, you have cancer and you're going to choose active surveillance with a 1% risk. On the other hand, you might have a tumor with active surveillance and a 5% risk of recurrence. So hands for scenario A. Someone wants cancer. And scenario B. Okay. So I found that interesting, actually. Anyways, we'll talk about that afterwards. Scenario 3, and the last one here, a tumor and active surveillance with a 5% risk of recurrence, or a nodule requiring surgery, and there's no chance it'll come back. And for A. And B. It's closer to 50-50 on that one. Okay, so the way we distributed that survey, that was an online survey that we designed, and we distributed it using a service called Amazon Mechanical Turk. You may or may not have heard of it, but what it is an online kind of repository of people who are sitting there waiting to answer surveys, essentially. As a requester or as a survey administrator, you go and you design this task for people to accomplish. And there's a huge list of potential things that you could assign people to do, including tagging images, phoning restaurants and verifying, their hours of operation, or transcribing documents. A lot of things that could be done with a computer, and sometimes are a little bit better done with a person. So the requester then sets a compensation for every task that people do. And people do this for a remarkably low amount of money, like far lower than minimum wage, because they sit there usually while they're at their job or whatever, and they just kind of click through things. And so you can also set certain qualifications that you're required of workers. For example, you could set certain demographic characteristics, or you could set certain quality standards that they've met in the past. And
does anybody know where the term mechanical turk comes from?
Yeah, actually, I don't either.
You know?
No.
Oh, okay. I don't either.
Oh, okay. I thought you were going to enlighten me.
No, I do.
Okay, yeah.
I don't know the exact. It's a historical reference to a chess playing machine from, I don't know what era, pre-computer era, certainly maybe say the 1800s. So there's a machine that would play chess against a human, and it's very impressive, isn't it? But it turns out there's a person inside the machine that's moving the pieces from underneath. So it looks like a machine is doing your work, it's actually a person on the other side.
Good to know. Okay, so and then the worker basically browses the list of all the tasks that they're eligible for, and then they go for it to complete it. And if they meet the pre-specified quality standards that you set, then they get compensated. And what's impressive about the service is how fast it happens. It has to do with the sheer number of people who are signed up on this service. So we did 5 pilot distributions of our survey while we were kind of working through some of the wording and making sure people understand the experiment. Each of those we decided to collect data for 100 respondents, and each of those pilot distributions took about an hour. So we did all 5 of them in 2 days. Then we did a final distribution to about 1,200 respondents, and around the same time per respondent. That took us 8 hours, so just basically one day, and we had our results back. This is a kind of a more of just an extra piece. Is mechanical Turk basically works based on your reputation. It's sort of like eBay. You're as a requester, people who do accomplish your tasks or sign up for them will do it based on your reputation for paying people on time, the reputation for how challenging your things are. So it's nice to work with some third party who has a reputation on the service already. If you haven't done many of them yourself. One company, and then the one we use is called Dalla. They're a Canadian-based company, which is also important because it's mainly U.S. respondents, and so it's difficult to sign up as a Canadian. There's various tax implications, but it's difficult to sign up to pay Americans from Canada. So Dalla does that for you. They've worked with a number of academic institutions doing that. So because it was an online survey and because people, like I mentioned, sit at work and they click through things pretty quickly, you want to make sure that the answers that you're getting have some quality check to them. What we did was we set really 3 different criteria. The first being that people accomplished it in a realistic time frame. They spent kind of long enough on the exercise for them to have actually possibly read it. And we had people do 8 choice sets each, and we said if they did 8 in less than 2 minutes, we thought that there's no way that they were actually reading it. So we excluded those people. We also included kind of 2, I want to say like trick questions, but they were like attention check questions. Basically, we fixed the biopsy report and we fixed the treatment offered, and we put an exaggerated difference in the risk of recurrence. And if people chose, we call it the wrong option, but the higher risk of recurrence is something that they preferred, and with everything else being equal, then they were excluded. And also we looked at the proportion of people who selected one side over the other. So if they just click A, we looked at the overall distribution of people, and we found that it was essentially 50-50, the number of A choices and B choices, so we were pretty satisfied that that wasn't happening. And then we'll have George come in and chat a little bit about the analysis.
Thanks. So I've seen people talk about discrete choice experiments before. Ahmed Baghi is here last year or early this year talking about an experiment he'd done. And it seems a little bit like you're getting something out of nothing. You ask people to make a choice between 2 sets of scenarios, and then at the end of it, you're saying, well, this variable is important, this variable is important, and so on. So I just want to give you most of you do some kind of modeling or analysis yourself, so I want to give you some insight into how you take the responses from the survey and translate those into quantities that represent the strength of people's preferences for cancer, surgery, and different rates of progression. But before I do that, how did you find, we didn't give you a lot of time to do it, maybe we didn't give you 15 seconds for a question, but how did you find the choices? Did you find it easy to make a decision? Did you, those of you who took it seriously, did you try to weigh off the different components on each side?
Like, this was easier than other demonstrations I've seen just because there were only 3 attributes.
Yeah. Which
for me anyway is a lot. Like I could actually entertain all 3 at once, kind of.
Yeah.
But,
yeah. Okay. So that's, I think I've seen some with more attributes. I think it can be challenging, especially if you've got people who are, if you look at older people with disease already. But these as Peter will show you, are fairly computer savvy, probably quickly reading things on screens. So, and 3 attributes make it easy to keep in your head at once. So that's what I thought. I've seen some other ones with 6 attributes, and when they're all different on each side, it's probably maybe more difficult to make a decision that reflects what you do. So with our study, so we have these 3 attributes: the name, the treatment, and the chance of progression. And to sort of represent that internally, when we did the analysis, we used dummy variables. So we have 6 dummy variables, x1 to x6. I'm just going to show you, for those of you interested in these sorts of details. When it was cancer, we had x1, x2 are the dummy variables for the naming. So x1, x2 go over 0, saying it wasn't a nodule, it wasn't a tumor. It was a nodule. Sorry, this is an error here. X1 is, I've messed this up. X1 should be 1, X2 should be 0, and this is 0, 1. So we use dummy variables for each of these levels. So 1 dummy variable here, X3 is 1 or 0, and then there's 3 dummy variables here. And then originally we set it up, one to be a reference, which is the highest rate of progression. Okay, and how that works then in practice is when we have the data from someone's response, we know which scenario somebody chose. So we have either they chose this or they chose this. We have the 2 sets of attributes describing those 2 scenarios that they're presented with. Right? So this is one of the choices you were given. So I encode one of the options as this, and the other option is this, and I know your response. So my outcome is either 1 or 0, saying you chose the left side or the right side, and these are the predictors of that choice. Right? So we have that it was a nodule, and it was active surveillance here, and it was 2% chance of progression. Notice that when 2 things are the same, obviously they get coded with the same dummy variables in both scenarios. Okay. I just press next arrow. Okay, this is kind of a lot on here, but we are THETA folks mostly, so we're going to go through this and learn. So that's the way we represent the data, and then we say, well, our outcome is a binary outcome. You chose scenario A or scenario B. So faced with 2 scenarios, we model the probability of choosing, say, scenario A as the utility for scenario A divided by the total of the utilities of scenario A and B. So if your utility for scenario B was 0, you absolutely hated it, then you probably choose A if you want. If your utility for A was 0, then probably choosing be 0. And if you're indifferent between the 2, utility would be half for each, then you probably, so if you listen this are equal, then you're probably choosing either one, just a half. And so this idea of a utility, which is your strength of preference for a health state, and how big that is compared to the preference to all the other things you're faced with, is what determines your probability of choosing the health state in the numerator. And how do we relate this utility to the description of the health state? We use this exponential function, so it's just e to the sum of the dummy variables times these coefficients. So we have the x's, which describe that system. We've got scenario S, which is one of those scenarios that I showed you in the previous slide. So x is either 1 or 0. So the utility for a given health state depends on the character, how you describe it with the dummy variables, and then these unknown parameters beta. So maybe you can now see what we're interested in. This really is estimating those betas. So we have the choice, the scenario somebody chose, that's the outcome, 1 or 0, the left side or the right side. We have the axis describing the 2 scenarios being presented to someone, but we don't have the beta, so it's interested in estimating. So we have, putting this into here then, the probability of choosing A is the utility of A divided by the sum of the utilities, which you can plug in that right side over there, equal to the sum of the betas divided by the 2 sums. And then the last part, I guess, is the interesting part, as far as I'm concerned, is that if you divide, well, I don't know which one to point out, if you divide the numerator into the denominator, so notice the e to the sum of the x betas is the same on the top and the bottom on the left, that becomes 1 in both places, and then this part down here, the bottom right, becomes 1 plus e to the difference in the axis times the beta. So all that really matters when you're working out the probability of choosing scenario A versus B is the difference between the 2 sets of characteristics. So going back to here, when we have characteristics that are the same in both sides, which is the chance of progressing being 2% on each side, this chance of progression has no impact on the decision here, only based on the name and the treatment, because you're presenting something with the same options on both sides. Now you can't tell, if you only had one scenario, you wouldn't know whether it was which of these two variables had an impact. That's why I present multiple combinations. Any questions about that? So this is, it looks like a logistic regression model in the end, where you've got an outcome 1 or 0, saying that you choose the left side and the right side, and the predictors are the characteristics of the left side and the characteristics of the right side. And as Peter said, each person did 8 different scenarios, and different people did different combinations of scenarios. So, pop quiz. How many different combinations of scenarios are there? There are 3 levels here, 2 here, and 4 here. How many different scenarios can we describe? Someone should say it.
24?
24! Right? 3 times 2 times 4. So 24 possible scenarios. That's not the end of it, because we present a scenario on the left and a scenario on the right, but it's never the same scenario. We don't have someone to choose a preference between 2 identical scenarios. That would be a waste of a screen of options. The 2 scenarios are all different somewhere. So there are 24 possibilities here, and on the right there are 23 possibilities. So there are 24 times 23 possible choice sets. Turns out to be 552 choice sets. So we had around, the numbers coming up, we have around 1,000 people doing 8 of these each. So we have 8,000 responses divided by 550 combinations. We have, on average, around 16 people to each combination of choices. So we have a lot of data here to estimate the betas, to say how important the attributes are. So then, what does the analysis do? The parameters are called preference weights. I use that term and talk about the results. And fitting a discrete choice experiment model, it means estimating those values, the betas. They quantify the effect of the corresponding attribute level on the probability of making the choice between the 2 scenarios when they differ on that attribute. And in case you're wondering, I'm not sure anyone thinking to this point, but we can multiply the utilities by any number. We could say they're 10 times as big, or half as big, or 100 times as big, and the probability would be the same. Now, the actual utility doesn't have to be a 0, 1 number; it just has to be larger than 0. So that means the betas themselves, these are e to the bunch of betas. So we could multiply this by any number, and we get the same result. The betas themselves have no meaning. Unlike in logistic regression, where you can say the odds ratio, the log odds ratio, or it's the slope in a linear regression, here the actual size of the beta has no meaning. And because of that, somebody might do a discrete choice experiment to show my betas are -1, 0.2, and 3, and someone else might do want to get 5, 0.7, and 9. And you say, well, how do I compare those? Well, you shouldn't, because they don't have any meaning by themselves. So what people often do is they rescale the estimates to line a nice range, of -10 to 10, or -1 to 1, or -100 to 100, because it's a nice round number. It's easy to compare things when they lie in that kind of range. And then the third thing we do for rescale, second thing to rescale them, is we recover the missing level by, because we have a dummy variable, which is 0. We recover that within each set of attributes by making the betas all add to 0. So we have the third one becomes the sum of the other 2, negative sum of the other 2. Just so we have a coefficient for all the levels, not just one of them. How do we do this? There's commercial software called Sawtooth, which allows you to fit discrete choice experiments. We didn't use that. We use code in JAGS, which is code for fitting Bayesian models. We fitted a series of models of increasing complexity and variation. We tried a fixed effects model saying all respondents have the same betas. Now, we didn't really do a formal summary of you guys in here, but not everybody has the same preferences when we showed you the 2 choices. So presumably, each of you might weight the importance of cancer, progression, and treatment differently from your neighbor. Okay. But a fixed effects model assumes that we all have exactly the same betas, whereas a random effects model allows that you might have slightly less aversion to cancer than your neighbor because you know more about cancer and you're not so scared of that word. That's just a term. It doesn't mean you're going to die from the disease. And someone else might say, I hate surgery. I can't stand being cut. I'd much rather just wait, even though it gives me a higher chance at progression. So, if we really think that people have different preferences, then a random effects model says each person has their own betas. Makes more sense. We tried a correlated random effect, independent random effects. We tried reducing the number of random effects by saying, well, maybe for risk, we have one 0, 1, 2, 5%, rather than 3 dummy variables, why not just have a single slope saying that the beta is just a single slope and the predictor is the actual risk of progression rather than the categorical dummy variable. So we tried a sequence of kind of variations to see what fit best, but we don't really know what the right model is. And to choose between them, we use this summary measure called the deviance information criterion, which combines how well the model fits to the data with a penalty for how big the model is. So in the simple fixed effects model, we only have 6 parameters, 6 independent parameters. Whereas in the random effects model, each of the 1,000 people has a set of 6 parameters. Not exactly, but there's a lot more parameters. You get the idea. So we didn't want to just say, well, the bigger model fits better because bigger models have more parameters. And now I'm going to talk about this. Yeah, sorry, this is the part. You see, I made this slide, but I'm going to talk about it kind of intervenes. So we had 1,038 respondents. We made some exclusions based on, I'm not sure the exact numbers, if you remember. We had a small number of exclusions based on people doing this study too quickly. It was a fairly small number.
Yeah, like 30 or 40 people.
Yeah, most people took it very seriously. We had some people excluded because they failed the logic checks and they preferred a scenario with a much 15% progression rather than 0% progression, which can tell you they're probably not reading the descriptors. And then there's a small number of people who were excluded because the demographics they reported a family history or personal history of thyroid cancer. That was about 2%, 29 people, something like that. We have the median age in the entire range. And the median age is 35, so they're fairly young, but they do range across sort of most adult ages. A little more than 50% female. Most of them were in good health. Some people reported moderate health, but fairly small proportion bad and very bad health. And maybe as you expect with people who are active on a computer, they're fairly educated, college or university degrees. Any comments on the respondents? I guess a question you might have, since no one's asking a question, I'm going to ask a question myself or Peter. What kind of people kind of people discovered to have these thyroid lesions?
Yeah, so particularly with papillary thyroid cancer, the demographic would be, and especially with the increasing incidence, it would be more common in females, so a little bit of female predominant. It would be a young age, but the median age would be a little bit higher than 35, something, or maybe Jesse probably know, but probably something like 45 or 50 would be the median age.
Well, the actual most common malignancy in young females is thyroid cancer,
right.
And the fastest growing malignancy is women's. But yeah, probably 4 to 1 female to male.
Right.
And
yeah,
35.
And are you fairly healthy when you discover it? And you don't know you have this stuff in an incidental finding, or just something from blood test. So you mentioned, well, these are healthy young people. How are their preferences? Why do you care about them? I guess increase the age of it, and these people should be making these decisions. They are mostly healthy people, and not that old.
That would be considered for this. There are a larger cohort of patients that are now being considered for active surveillance that are of the elderly group. But in a subgroup analysis of the paper that he was talking about from Ito in Japan, the ones that actually did worse for active surveillance were the elderly people. So that's been pushed back by another group. But anyway, so young people are the people that we would want to look for the most for this. That's a perfect demographic.
Okay. I was lucky. As I said, we fitted a number of models, and you can see on the right-hand side of the deviance information criterion, which no one called DIC.
Yeah.
This is deviance information criterion. And it's a big jump going from a fixed effects model with just 6 parameters to the random effects model in the second line, where we have an estimated, using the PD, an estimated 1,573 parameters. We have 1,000 people. We don't really have the maximum number of parameters, which everyone gets 6 random effects plus all the covariance stuff. We don't have that. We have an estimated around 1,600 parameters. And that second line was the best fitting model by quite a bit compared to everything else we looked at. So that's what we present results for. So the best fitting model says that people don't have exactly the same preferences as each other. There's variability between them on all the attributes.
What's the correlation? Is it correlated in terms of what?
We have a vector of 6 betas. So we're saying that they're kind of multivariate. Each beta has a correlation with each other. So if you have a preference for watchful waiting, maybe you also maybe don't tolerate risk so much. So maybe your preference for 5% progression would be lower. We didn't really look at that. It would tell you how the preferences relate to each other. So someone has a higher preference for watchful waiting or active surveillance. Does that mean that they don't mind progression of cancer, or they do mind progression? All right. And how does that relate to the preference for a name? So, it says that maybe those preferences kind of go together in some way. They're not just independent of each other. So to test that assumption, we fit this model where we said there were potentially quite a lot fewer, 15 fewer parameters, because we said the correlations are all zero between them. That model didn't fit so well. So it seems that the data suggests that there's something about those preferences that having one preference means you probably tend to have another kind of preference as well. Right, so this is one of the ways of presenting results. You can see we standardized these are the estimated betas, not probabilities or not utilities, but the betas, which are the coefficients that go in that model to predict the preferences. And we standardized them so that the lowest average value from the Bayesian output is in value -10, and the highest one is a +10, and everything else lies in between. And these are the 95% credible intervals. You can see them with a large sample size. They have 8,000 plus people doing 8 questions each. We have pretty good precision on estimating the average effects. I'm going to throw it open, and then we want to comment on what does this mean? How do you know what you know so far about discrete choice experiments from this presentation and our study question and hypotheses? What would you say you've learned from looking at this? John?
People really don't like being told they have cancer, and they really don't like surgery, and they really like having zero chance of, recurring.
Yeah. So the least in each of those categories, cancer is by far the least preferred. Nodule is the most preferred. Surgery and active surveillance, I told you that we said so they add to 0. So surgery and active surveillance are just the negatives of each other. So those two parameters add to 0. And then risk of recurrence follows a logical pattern. There's no, on average, people don't ever prefer a high rate of progression. Some of you may have been here, remember earlier this year, I sent an email around asking people to put these labels in order and send them back to me, cancer, nodule, and tumor. I thought this is kind of the order in which most people would put them based on their intuitions. So what is the benefit? I mean, I think if I asked you the question without having done this study, do people like a higher rate of progression or a lower rate of progression? Do people like surgery or waiting? And do people like being told they have cancer or something else? You probably already know the answer to those sort of yes, no questions, right? So what else do we gain from this? And so John pointed out, there's a qualitatively, you can say people really don't like cancer, they don't like surgery, and they don't like their disease progressing. But we've got more, we can say more than just that. Otherwise, we probably wouldn't need to do discrete choice experiment, because simply ask people that simple question about who you like, who told you have cancer or a nodule. Of these 3 factors, which is the largest effect on choice? I don't mean which parameter. Of these 3 attributes, disease, label, treatment, risk of recurrence, which one has the largest, across the range we presented, which one has the largest effect on choices? Recurrence. Right. Yeah, recurrence. Yeah. That's one thing we get from this. We can quantify the size of the effect versus other, and it's not an absolute effect; it's only relative, because we could change this axis to be -1 to 1, and we get exactly the same interpretation of the range.
That's a question. Can you say anything about the magnitude, for example, for surgery versus active surveillance, in terms of how much more that people prefer active surveillance to surgery? Because I know that this is just a mirror image in the negative, so you can't really.
Right. So I'm glad you asked the question. We do show the next slide actually might have. So this is kind of useful by itself, but our question was, well, we know people probably don't like to be told they have cancer, more much for being told you have a tumor or a nodule, how much? So with this model, we can quantify any one of these preferences in terms of any other one. So I think where you're saying how strong is that preference between surgery and surveillance in terms of, we can quantify it in terms of risk of progression. So going from surgery back to surveillance, that has as much effect on person's choice as what? Our focus really was on the other question, which was, if you tell someone they have a tumor versus cancer, how much more how much is that going to matter in terms of they'd be more willing to take surgery? So will people trade off being told, they'd have surgery to back to surveillance to avoid having cancer? Or would they put up with a certain more high risk of progression to avoid being told they have cancer? That's the kind of the question that we can answer with this.
Or similarly, like how much would someone prefer active surveillance over surgery in terms of risk of progression? Would they be willing to accept the higher risk of progression in order to avoid surgery? That's how you can.
Yeah, so we didn't really present results on that in the paper or here, but that may be more of interest to surgeons. We were kind of interested in this more touchy-feely thing with the naming. So I told you we had random effects models. So those are the average values, right? So these are the averages and the credible limits around the average, but there was quite a bit of heterogeneity of individuals around the average. So these little gray boxes in the red lines here are the same data points that I showed you. So this is -10 to +10. But you can see in these, so John Matelski you have to blame for the violin plots. These violin plots are like where they're wider, there's more evidence that's where the parameter value lies, and where they're narrower, there's less. Okay, so where they're fat, then there's a lot of concentrated values around here. Where they're thin, they're fewer, and this is sort of it's like a histogram on its side. Okay, so the random effect across 1,000 people, we can see when it comes to management, there's quite a bit of variability. Right? People, this one's just a mirror image of the other one. Whereas for things like a 2% or 1% chance of progression, really people don't vary very much. And then when it comes to cancer, tumor, and nodule, but even with all the variability, there's still those three groups are still quite well separated, even though there are people that have different preferences from the average. So with this, we didn't do this. We don't present anything on this, but you could actually say, well, if you took a sample of people from this population, how many would actually prefer to have cancer? So you could actually predict based on those, taking these individual preference weights, and who would prefer to have, so to answer your question, how many would choose to have surgery to get the cancer out to avoid a risk of progression? And then finally, we can, rather than just kind of pointing at the graph and saying what that effect is bigger than that one, by this much and that much, this is what Peter is alluding to. There's a quantity you can calculate called the marginal rate of substitution, which doesn't really have a lot of meaning unless someone tells you what it actually means. I don't want to go into something more descriptive. And it answers the question of how much you would trade off one attribute to avoid another attribute or gain another attribute. So we'll go over to here, and this is probably the easiest one to see to start with. So this is when we compare nodule versus cancer. Okay, so how big is that effect compared to the effect of active surveillance versus surgery? And you can see that on average, that effect is around 1, which means that people would switch treatments to about the same degree as they'd avoid being told they have cancer over a nodule. If I say, would you like, if everything else be equal, rate of progression is the same, somebody would switch from active surveillance to surgery to avoid being told they have cancer, to be told they have a nodule instead. Or the other way around, if you're a physician telling someone what disease you think they have, if you say nodule versus cancer, that could have quite an impact on their choice to have surgery or active surveillance. The preference for those two states. And then we can quantify this in terms of the rate of progression. So how big is that effect? Calling someone with cancer versus a nodule, it's about the same as 1% versus 5% progression. So it's 4% increase in the progression rate. For people to avoid being told they have cancer would accept a 4% increase in the chance of their disease progressing. So rather than just a yes, no, we can actually quantify how big those effects are and put some kind of credible limits on the ratios of those effects. On the other side, you can see tumor. is not such a benign word as nodule, so the effects are a little bit decreased. People wouldn't accept. So this is at a value of 1, meaning it's about the same as active surveillance versus surgery. Tumor versus cancer is not as big an effect in terms of active surveillance versus surgery, because these two things are closer together. So going from tumor to cancer is not such an, so going from cancer to tumor is not such an improvement, so it's not as big as going from surgery to active surveillance. So all the values over here are decreased because this is just less of an effect. Comments, questions? You're just going to, sure, yeah, accept that. Bring us home.
Sure, yeah. So then, kind of like as a secondary analysis, one of the benefits of having such a large sample size is that we could look at small subgroups of choice tests, and ones that we found were like particularly clinically interesting. And we defined a particular possibility of making what we call a paradoxical choice, and this was a choice that contradicted what the revealed preferences were based on the discrete choice experiment. So we looked at scenarios where the diagnosis was the same, so it's kind of more clinically accurate, where you tell someone the diagnosis that they have, and then you offer them and you tell them what treatment option they would have and what the associated prognosis of that after that treatment would be. And we defined a paradoxical choice as a choice where someone would choose a more invasive treatment, even if that treatment resulted in a worse outcome. Which seems to not make any sense, because we know that patients prefer active surveillance. We know that patients prefer, a lower risk of recurrence. And what we did was we compared the rate of making this paradoxical choice when both scenarios had the diagnosis of cancer compared to when both scenarios gave any other diagnosis. And we found that in 27% of the time, patients made a paradoxical choice under the cancer label, compared to about 9% of the time under any other label. So the risk ratio for making a paradoxical choice was about three times higher under a cancer label compared to other labels. So this is telling us that people seem to behave sort of almost irrationally under a cancer label in order to have a desire for that more invasive treatment. So to summarize, we did show that disease label influences how patients think about low risk malignancy. The betas for the naming effect were not 0. And we showed that the magnitude of that effect was pretty large. It was equally important to people when they made the decisions as the treatment they underwent, which to me seems crazy. I think that someone should really consider the treatment that they're undergoing and the relative prognosis after that treatment. This should be much more important to them than whatever the label of the disease is, but it doesn't turn out to be the case. We also showed that the word cancer was associated with paradoxical decision making. And just to summarize a bit, summarize the methods a little bit. Discrete choice experiments can be used to quantify preferences for various attributes of a health state, which we know, and to remind you about Mechanical Turk, which is an efficient and cost-effective resource for our online survey response that we might consider in future studies. So we're not the only group that's looked at this sort of thing. It's actually sort of a relatively hot topic. It has been for a few years, actually. This is another study published by a group in Australia, and they did a slightly different design, which is exactly a design that we considered when we first conceptualized this project, which was just to randomize people to, your disease is called cancer, what treatment do you want? Your disease is called nodule, what treatment do you want? I think the benefit of our approach was that we were able to first quantify how big that effect of the label was, not just in showing, the various treatments that people undergo under various disease labels, but how important those labels are in their decision-making process. And the second benefit is that it avoids this labeling order effect. So people were given multiple scenarios, and each time just the label changed. And in this study, they showed that it mattered actually whether you saw cancer first, or you saw a lesion first, you saw abnormal cells first. It affected the odds of choosing a more invasive treatment. And in fact, if you were shown a more benign sounding term first, then you were more likely to choose an aggressive treatment when you were shown cancer later. So in terms of implications, I mean, knowing that there is a cancer label effect, which might not be surprising to people, what can we do about this? One strategy that's been kind of lauded in some of the more recent guidelines for papillary thyroid cancer and as well in other low-risk malignancies is to raise the threshold for biopsy to say, okay, well, this tumor is under a centimeter large, it has these certain characteristics on ultrasound. It could be a cancer, but in all likelihood, we wouldn't do anything about it. So let's not biopsy it. Our study doesn't really exactly answer the question of how that settles with patient in terms of their anxiety levels, knowing about the cancer diagnosis. But we did show that if we give patients a diagnosis of nodule, which is essentially the diagnosis they would carry forward if they didn't have a biopsy, that they're more willing to undergo active surveillance. The other option is to change the disease label. So diseases that we now know and call cancer, if they're low enough risk and if maybe their molecular profile is such that we are fairly confident it's unlikely to spread or cause death in the future, maybe we could not call it cancer anymore, which is another strategy that's been suggested. Of course, that has other collateral effects. Survivorship, people who have had that cancer then survived it, and we've removed that name and now tell them they never had cancer. It can be confusing for people in terms of the treatment that they underwent. And then the other thing is whether or not cancer, the word itself, can motivate the surveillance adherence. So patients who are on an active surveillance protocol, if they know they potentially have cancer and that we're monitoring it to make sure, it might motivate their adherence with their follow-up appointments. It actually might motivate clinicians as well to make sure they're diligently ordering the tests and following up with the tests as they come across their desk. Whereas if we remove the cancer label and tell them, this is not cancer, but we're still going to watch it, people may be a little bit less motivated to stay on top of things. So just some food for thought. And just acknowledge the rest of the co-authors of the study who've been all very helpful. That's all. Any other questions, comments, answers?
Great work. Do you know of a way to recruit Canadian public members using similar systems?
I don't actually. I haven't looked into this for a couple of years. We did this a couple of years ago, but I know that there are some Canadians on Mechanical Turk, and it may be a little bit more receptive to the Canadian population now. But I don't know of any other online resources like that. I don't know if anyone else does. Anyone has recruited online survey responding Canadians? Sorry.
So this company, Turk Data, you found quite helpful.
Oh, they're inside it. You know what? The other really amazing thing about them was that I said I want 1,200 respondents. And I did that calculation, frankly, thinking that, okay, so a certain number of people are going to just click through, a certain number of people are going to fail the logic checks, a certain number of people are not going to be my demographic inclusion criteria. But they interpreted it as, okay, we're going to get you 1,200 people for that price that fit all of your inclusion criteria. So they gave me 1,200. I said, these 300 I had to exclude. They said, okay, we'll give you another 300. And then we'll give you another 100. We'll give you another 50 until we got to 1,200. And it was at the price that we did $1 per respondent, and they told me that was high. So it's, and they were very, very helpful. They provided all the data to me in spreadsheets.
Mm-hmm.
Yeah.
Okay. I have another kind of common question about your paradoxical responders.
Yeah.
So you have the two pie charts.
Yeah.
So more people with a cancer diagnosis would almost make more irrational choices.
Yeah, so if you were so the paradoxical choice in this scenario would be to choose the scenario on the right. So that's choosing surgery, when the result of that surgery is that your disease is more likely to come back. And the disease is called the same thing, so that effect should be eliminated. So essentially, 3 times as likely for people under the cancer diagnosis to make that paradoxical choice.
If I understand the 3 choice experiments, one of the premises is people make rational decisions and they don't make irrational choices. So would you then discount some of the reliability of the data based on?
So yeah, we have to be careful about the word rational and irrational, right? This is more in keeping with there being some sort of interaction within rather than it not being rational or irrational. And maybe George can comment a little bit on the analysis, but yeah, it doesn't have to necessarily be, it's not necessarily irrational, because you can't tell someone that they're irrational because they want to have the cancer removed. That's just their preference. Whereas, you know, what it does is contradict their revealed preferences in other scenarios. You know, all I can tell.
Yeah, we haven't really looked into this too much. And one thing to point out, this is about 500 small choice sets out of 8,000. It's 1/16 total sample size. And the second thing is, I'm just wondering if this could be explained partly by that between person variation. Maybe there are some people who don't follow the overall pattern. You know, the overall pattern says that they should make a certain choice, but then individually there could be individual preferences that match up with that.
Like the shape
We
of
haven't thought
the.
about that so much.
Okay.
I mean, clinically speaking, you do see patients that, when presented with both these scenarios, do say, I want surgery, and this is very common, I want surgery, even though it's very clear, if, like, from most analytical thought process that we talk about, looking at data, it would not make any sense to go for surgery in that scenario. But a lot of patients do that, and part of it has to do with not understanding what recurrence or what progression actually means, and what the implications of a failed therapy does. So I think that's kind of the main thing, and I can see that. I mean, I look at that data, and I look at those data, I think that that's actually what I would expect people to say in some of those scenarios. At that rate, even higher, but you're catching 1/4, but I think it's probably more in clinical practice.
Right. We did look at interactions at the overall level. We didn't find interaction in the whole sample between the disease label and either the management strategy or progression.
Yeah.
But I mean, I wonder if it is part of just some small subset of people that have that.
Yeah.
Set of betas.
Or it just maybe in this particular display of the way that it is presented in this potential choice, that maybe that there's more interaction, if that's possible.
But maybe I missed at the beginning, when the patient provided information with some mortality information about cancer, nodule, and tumor between, like, comparative
Mortality information?
Yeah, at the beginning when they
in
start
every
rating.
choice that there is a note here that says the chances of surviving this condition is more than 99%, no matter what. Yeah.
Okay.
So they were told that at the beginning, and they're reminded every time they made this decision. Yeah.
About your conclusion for the last slide, labeling cancer and motivation. Just general comment, not for this specific. I'm not sure completely is going to be reliable, because if I label as a cancer, then the interpretation of active surveillance is completely different. Active surveillance back to something, you know, some kind of prevention, primary prevention. So if I told, for example, labeling as a cancer, so I'm looking for the active treatment.
Yeah.
You know, not just watching the disease. So the motivation of just choosing the active surveillance, I think, if I label as a cancer, is going to be less.
Oh, you think less?
Yeah.
That's interesting. You mean, I don't know. I don't, maybe Jessica, comment if you, I know that there's a trial now that they're registering patients for. I don't know if either of you have recruited patients for it, but in conversations with people, if they know that they have a cancer, and, you know, if they've opted for the active surveillance or been randomized to active surveillance, my point just being that, you know, if they do opt for, among patients who've opted for active surveillance, if you tell them that, you know, this is potentially cancer, we need to be diligent about watching this and, you know, moving forward, that I think that they may take the recommended follow-up protocol a little bit more serious, and they may place a higher priority on making sure they attend their ultrasound appointment, and that, you know, they're diligent. Let's say for whatever reason there's something falls through the cracks and the ultrasound appointment at one year wasn't ordered, and, you know, patient might be a little bit more diligent about making sure that that was picked up. Whereas if you tell them, you know, this is it's not cancerous, you know, but we're going to keep an eye on it. It's a little thing we're going to keep an eye on, but, you know, then things get in the way, and, you know, work and other things, and priority, I think, to me, it would seem like it might decrease a little bit. So maybe not, I don't know.
The EDO paper that Jenny talked about 16 or 17% of patients actually got thyroidectomy.
Yes.
Not because they had progression, but all because they were just anxious. They got worried, and then over the course of a few years, they underwent surgery.
Right.
Less than probably 0.2% developed lymph node metastasis.
Yes.
In that early cohort. So it's very, very low that we'll have any problems, but people just go. It's hard to know. I mean, it's all culture, right?
Yeah.
I wonder if we did this survey in the Japanese area where they have a lot of well-known people talking about this. If it'll be different answers, right?
And can this type of tube cancer progress a more severe type of cancer with a higher mortality? So why this surveillance is needed then? So you are watching them.
The point is that it is very unlikely for tumors to grow and metastasize, as Dr. Kastner pointed out, but some of them do, is the bottom line. And we're not, while the molecular profiling and our understanding of tumor biology is improving, and we're having a better idea and we're better able to estimate which ones are going to progress and which ones are going to cause problems down the road, we still there's some uncertainty around that. So, you know, you could tell someone it's 99.9% chance this is not going to cause any problem, but there's still a 0.1% chance that this could kill you. So that's why we watch them.
Okay, so we'll wrap up then. So thanks, Peter.
Thank you very much.
Oh, yeah.
Oh, thank you.
Thanks for having me. Jenny, I think I met you. Yeah.
Just wanted a bit more people coming. It's a great topic. I found that students are interested in a way.
Yeah.
And just talked to Peter Uni over at St. Mike's. It's very interesting to discuss that.
Yeah, it was a little last minute, but that's okay.
Alan came when I did talk on thyroid for this.
Yeah.
He heckled me the whole time, so it's good.
Yeah.
I'll see you.
Take care. Yeah.
Hi, everyone.
Hi.
Peter Dixon, thank you. I'm Julio from the university.
Oh.
Neurology.
Oh, great.
Quick question. Sorry, I missed that the first time.
No, sure. Yeah.
Meeting. But how are you selecting whether it's going to be surveyed? They have individuals that they have on their database that they survey, or you provide them with patients?
So they're all voluntary. So people sign up for this service in order to you know, basically fill out surveys and be compensated for it. So there's a you know, a huge pool, tens of thousands of respondents waiting. And what you can do is you can set up certain restrictions, like, so you can target a particular demographic. You can say, I want my median age to be 35, and I want the range to be this, and I want it to be 56%.